Yeah, and I'd like to welcome you to the Working for Health 2030, 2024, 2025 seminar series. And we'll focus today our discussions on training, recruiting, and retaining the health workforce in a globalized labor market. So before I begin, let me introduce myself. My name is Dr. Rispah Walumbe. I'm the Senior Health Policy Advisor at AMREF Health Africa. I'm also the Program Manager for the UHC Delivery Lab. But today I will be your chair for this session, and I look forward to really interesting discussions. We have a great set of panelists for you today, and we really want your engagement. We hope that it's going to be very exciting. Please make sure you ask all the questions you can. Please engage with us, be as deeply engaged as possible. But we look forward to a really interesting discussion today. It would be great also to just let you know that we will be recording this session, of course, just for documentation purposes, and that the recording will be made available to all of you within the next couple of days. And the session today is kind of split into two, where we'll have a presentation session for about an hour, and then we want to make sure that we give enough time for an active Q&A session and discussion. So as I had said, this is the first of 4 seminars, and we have about 4 panelists with us, and we'll be able to kind of take each of their perspectives, and hopefully by the end, I have a very easy job today, but hopefully by the end, I think we'll have made some ground in terms of, especially given this is our first seminar. So before I introduce the panelists, I will take this opportunity to just quickly frame the discussion. And if you could just go next. I hope you are clear on how the chat works. There's also going to be a Russian translation, so there's an interpretation button right at the bottom. And please feel free to use the chat function. I see some of you already in the chat session. It will be great for us to continue to get your engagement, and also the Q&A function. All right. So in terms of framing the discussion, so as I said, we're going to have kind of like 3 parts to this, where we'll have a speaking session, where all the presenters who are here today are going to take us through some of the key questions that we'll be answering today, and then that will be followed by a Q&A session with the team, and then of course we'll close and wrap up, and hopefully we'll have gained some ground. So continue engaging with us, and yeah. So our questions for today. So we have a couple of questions that we want to target, and hopefully our speakers will be able to, target focus their discussions around these 4 questions. But the first one is around what motivates people to choose to enter or leave the health workforce. And I think this is going to be quite interesting in terms of, having so many health workers from across the world joining in. It would be great to hear your insights and in your thoughts as we continue with the session. Our second question is going to be, what does the evidence actually show us are effective ways to improve retention? Our third question is going to be around what practical approaches and strategies help, healthcare workers to stay and thrive within the healthcare system. And then finally, we have, what are examples of, good practice, and how can they be applied to different institutional and system strengthening? All right, so those are just some of the questions. Next slide. All right, so I won't delve too much into this because, again, we have a really great list of speakers with us today. But essentially, the policy landscape, putting on my policy hat, there are a number of frameworks and policies and legislations at a global, national, and regional level that consider the health workforce arrangements and discuss several facets of it. And I think the key things here around what the policy discourse has prioritized overall has been health systems resilience, especially in the aftermath of the COVID-19 pandemic, and of course, improved health systems performance, just to mention a few. And if you look at them, if you look at these policies and legislations a little bit further, they kind of focus on, having a fit for purpose health workforce. And this really covers the full spectrum from production to recruitment to deployment, retention, motivation, performance, and of course, regulation. But in the face of this, we're actually faced with really, staggering odds with a projected 10 million shortfall of health workers by 2030, mostly in low and middle income countries. And, there are different global resolutions that have tried to focus on making sure we mitigate against this shortfall. And the global resolutions, span different key issues. And, even as recently as 2 years ago, we did have one of the resolutions at the World Health Assembly. And of course, now and as part of that, there was the Working for Health 2022-2030 Action Plan. And some of the discussions, even in the African region, have included the new public health order. So these are just some of the policy considerations and things just to keep us together, and hopefully we'll engage a little bit more further. Next slide. So in terms of what the operational context that we're in right now, healthcare workers are grappling with multiple crises on the front line, and especially a lot of crises that are outside of the health system, but do influence their work. And there are several economic shifts and political shifts and climate change and many other things that really affect your day-to-day work as healthcare workers. And as the challenges are multi-sectoral, maybe some of the considerations we might need to make for the solutions may need to take a multi-sectoral lens as well. So what should be prioritized for investment, given the multiple needs and limited resources that may be available to be able to make these investments? Next slide. So we have some pre-existing tensions in terms of what we're discussing. So we have the ambitions of having a motivated, fit for purpose health workforce, and want to retain healthcare workers, and make sure that, service delivery is seamless. But at the same time, there are different challenges at a health workforce level that include remuneration, in resources to deliver care, the workload, different harsh conditions, which may be working in remote areas, conflict areas, and of course, social conflicts even within the workplace, and also unclear growth trajectory. And then there are also system level challenges to do with migration, industrial action, and, absolute shortages that countries are facing. Next slide. So again, going back to the questions as I wrap up my, my little framing session, I think it's really important for us to focus on, those key questions around motivation, about retention, and together, I think we'll hopefully, harvest some best practices that can actually be scaled across different contexts, different institutions, and different systems. So without further ado, I'd like to take this opportunity to introduce our panelists. Our panelists today are, I'm going to start with Simphiwe. I'm pleased to introduce each of the panelists. And I'll start off with Simphiwe Mabhele, who is the technical specialist on health, wellness, HIV, and TB for the International Labour Organization. And it's a pleasure to have you here. So I yield the floor to Simphiwe, please.
Thank you. Thank you very much, Chair. Thank you, Dr. Rispah, and good morning, good afternoon, good evening to everyone. I actually just want to check whether you can see my screen. I'm just sharing my screen from my side.
Yes, your screen should be coming up shortly. Yes, we are able to see it.
Thank you. My input this morning, at least it's still morning where I am going to have a presentation in 3 parts. The one part is actually going to focus on ILO as a specialized agency of the UN and the tripartite nature of the organization. And this will just reflect on international labor standards, and then I'll locate the world of the health sector in the world of work. But I also want to reflect on a part where I speak about multi-sectoral action in the field. And this is where I cite some of the examples, and then finally some recommendations and policy proposals. But let me quickly start with part one. And if you were to ask me, Simphiwe, what does the ILO do, just in one line? I would definitely say to you, the ILO is an international labor standard setting organization since 1919. So we have a combination of protocols, conventions, and recommendations, and all these are international labor standards. So, Chair, for the purpose of this webinar, I selected, the international standards that are relevant to the health sector, particularly health workforce. And I won't go through all of them, but I do want to highlight a few. And where you see the ones that I've highlighted, it means it's two separate instruments, but related. For instance, let me start with the Nursing Personnel Convention, which is number 149, which is really focusing on nursing personnel and in terms of their protection, the movement, but it also has a recommendation, which is recommendation number 157. And we know that, yes, a number of member states have ratified this convention, but there's still a number of member states that have not. But it's also important to highlight Convention on Occupational Safety and Health, which really is a critical convention, especially as of 2022, because occupational safety and health has now become a fundamental principle and right at work. So there is now more that is required by the employer. And when I say employer, I'm also referring to government as an employer, not government only as a policymaker, but government as an employer, and the health workers that are also in the private sector. And we saw what happened during COVID-19, where the health workers were in the forefront, and they actually, due to lack of occupational safety and health measures. So this convention becomes really important. So there's quite a number of others. Some are newer than others, but they remain, those that are older remain relevant. For an example, one of the latest conventions is Violence and Harassment, Convention 190, which also has a recommendation, ILO Recommendation 206. And it's focusing on addressing issues related to violence and harassment in the world of work. And we know that the health workforce is also exposed to levels or high levels of violence and harassment in the workplace. But Chair, it's also important to locate the health sector within the world of work realm, because this space we refer to as world of work is quite a complex space. It's characterized by people who are looking for employment. For an example, we know, and as much as it is relevant to this workshop, the movement of health workers, and they move because they are looking for employment opportunities elsewhere. So the world of work is also characterized by people who are working in the public sector. So all the people that are working for government in various countries, they actually are employed. So government has a dual role in many countries where government as a policymaker and government as an employer. Then we also have the private sector. We know that there are health workers that are working in the private sector. And we also have workers in the civil society space. So it's important to acknowledge and recognize these horizontal sectors when we are dealing with the health workforce. And of course, there's what we would call vertical sectors, and that's where the health sector would be located, amongst other vertical sectors like transport, tourism, agriculture, and so forth. But if I move swiftly then to the second part, in terms of the multi-sectoral action that we talk about, it's informed by the decent work agenda. And one of the ways that I can simply define the decent work agenda is through these 4 pillars. One pillar, it's about rights at work. And this is the pillar that would host these international standards that I spoke about earlier. And in terms of application of the standards, enforcement, the reporting on these standards, then employment creation, which is linked to issues of skills. And this is very crucial when we talk health workforce. Then the social protection, which would relate to issues that have to do with social security, occupational safety and health would also be located there. But then, most importantly, decent work is also measured through social dialogue, where we, as ILO, we encourage actually that the health workforce, together with their representatives, they become part of what we would call social dialogue mechanisms in the countries. So that they can be able to negotiate collective bargaining agreements and all that. But the health workforce is not spared from what we call decent work deficits and challenges. And there's a plethora of these. They range from inadequate remuneration. There are issues of work-life balance, and as much as mental health issues have been there, mental illnesses, but I think there's now an emergence of mental health related illnesses as well. And I spoke about violence and harassment. Health workforce is also exposed to limited career advancement opportunities. And these are actually deficits when it comes to the decent work that I just presented on. So what we have done, both at global level and in the field, we have actually looked at this from a multi-sectoral point of view and using the tripartite structure of the ILO in giving equal voice to governments, employers, and workers. And this actually has a specific convention in the ILO, Convention 144, on tripartite consultation. So because my role is in the Africa region, so I'll reflect more on the Africa region, where we would facilitate government coming together with workers and employers. And workers in this case would be more your health sector unions. And government is not limited to ministries of health, but we're talking ministries of employment and labor in various countries, because they are responsible, they are the custodian of legislation that is linked to the employment and labor space. So employers would also be those that are in the private sector. But once again, we're not forgetting that government also should be looked at as an employer. And then we would have workers where we would work with the regional and sub-regional bodies of workers, because the health workforce actually is one of the most organized work sectors in terms of workers. There are unions specifically for the health sector. So briefly in terms of implementation, and I'm just going to look at a global level, where in 2014, we worked alongside WHO to develop a series of materials, but I just selected one, which actually relates to this particular webinar, where we jointly developed a methodology called HealthWise. And if you look at the 8 modules that are in this tool or guide, one is specifically on the retention, training, and recruitment of health workers. So we actually developed this globally, but what we did, we brought it closer where we had activities at sub-regional level. For instance, one of the sub-regions we worked with was the Southern Africa Development Community, SADC, where we also worked with WHO, supported SADC to come up with a health workforce strategic plan. We also went at national and sub-national level, and South Africa, for instance, I don't know whether there are South Africans in the audience, but South Africa adopted a human resources for health strategy as well. And then we went sub-national, one of the provinces where we worked with the HealthWise tool. Then most recently, WHO spearheaded a process of developing an African charter Africa Health Workforce Investment Charter. And this is one of the milestones in terms of this space. So there's quite a number of these activities, Chair, that I can reflect on. I mean, we refer to some of these interventions as catalytic because we worked with government, we worked alongside development partners and other workers as well. Then the final part in terms of my contribution, Chair, is just a list of recommendations and policy proposals that I think moving forward, let us focus because we have different stakeholders and role players. Some are working on ensuring that we improve working conditions of the health workforce. Some of us are working on promoting equality and non-discrimination. There are some of us who are working on gender-responsive policies, while some are working on green and sustainable healthcare. Some on ensuring that there is skills development and recognition. So there's a lot of detail that is there in terms of players, in terms of stakeholders.
No, Simphiwe, have we lost you? It seems we've lost Simphiwe, but actually, the beauty is we're just wrapping up. But I think that's kind of like set the scene in terms of like from a global level, some of the the efforts that are taking place from the International Labour Organization. And I think what he managed to discuss was really critical, right? Especially the 4 pillars of work for 4 pillars of decent work agenda. And really what hit me is that this is actually a multi-sectoral, multi-stakeholder approach that was taken on. And there's still quite a bit of work for us to do. And I think as we continue to delve into the details of what that looks like, what even the fact that multiple ministries are involved in putting this together, it would be interesting to see how we continue the conversation moving forward. So without I'll quickly shift to the next speaker, and we have Peter Chalusa, who is the Health Systems Technical Officer in the WHO Malawi Country Office, and I'd like to yield the floor to you. Thank you.
Thank you, Chair. I will share the experiences in terms of healthcare, health workforce retention from the experiences from Malawi. Next slide. So we have an overview of Malawi just to highlight that the majority of the population of Malawi is young. 64% is under the age of 15 and 18% under the age of 5. So possibly we'll reflect on this later on, but also to highlight the fact that 82% of the population in Malawi is rural. And as you can see, only 12% of the national budget is allocated to health. Next. So just to also highlight that currently Malawi is implementing the Health Sector Strategic Plan number 3, which will run from 2023 to 2030, and health workforce falls under pillar number 4, which we've listed some of the key objectives under that one, but I think mostly focusing on how to improve staff development regarding policies, procedures, and practices, but also ensuring that there is enhanced recruitment, selection, deployment, and equitable distribution. And I think I also reflect on that in the next couple of slides. Next. So here we just showing the public sector vacancy rates across all the key health workforce cadres, especially the nursing, the medical doctors, lab technicians, and pharmacists. You see that the average is around 30% or 40% vacancy rates across all the cadres. And much of these vacancies really exist in rural communities, in rural or hard-to-reach health facilities. But also from the other graph on the right, you see that the overall retention is around 80%, which is relatively good. But I think we also reflect on the fact that the retention rates are poor for the rural communities. Next. Now, to directly answer the questions, first question is about what motivates people to choose to enter or leave the health workforce in Malawi. I think just to highlight that in Malawi, the public sector or the government is the major employer. So although I've highlighted here several factors like good working conditions, job security, opportunities to grow in the career, but also safe working environment. But I think largely job security working in government is key because people have few options really to, other than working in government or in the public sector, there isn't much opportunities elsewhere for people to work. So I think even as people as young people are joining the training colleges, the job security is key at the back of their minds. Next. So the second question is, what does the evidence show are effective ways to improve retention? So one of the major factors in retention, especially as I mentioned, that 82% of the population in Malawi is rural, only about 25 or 20% is urban. But in terms of health workforce, possibly 70% of the health workforce serves the urban 20%, whereas about 25 or so percent serves the 82% rural, which is a very, very big imbalance. But the major factor is the lack of housing for staff in the rural areas. So where you have housing units, normally the numbers of staff are better, and the retention of staff in those rural areas also gets better. That also goes along with availability of electricity, piped water, and other social services, but also broadly issues to do with career advancement for healthcare workers. Next. The third question was on practical approaches and strategies to help people to stay and thrive in the workplace. So from recent years, government explored and implemented a bonding mechanism where there were scholarships, and if a student undergoes training as a nurse or a medical doctor or a pharmacist or lab technician, they would be bonded to work in a particular area for several years as a condition to be recruited in the public system. Of course, that system worked, but again, where there is no housing, where there are no social services, deployment of staff to those areas has been a very big challenge. But also improving working conditions and relationship between healthcare workers and communities has also been noted to contribute to high retention of staff especially in the rural areas where there is a very big need. Next. What are some of the good examples, practical examples, or good practices that exist for learning? So, of course, in Malawi, there are a few examples. Number one, development partners have been putting resources to help construct better houses for staff in rural areas. And where that has happened, we have noted that retention of staff is also better. So I think that's a very good, good practice, but also enforcement of the bonding mechanism for staff who benefits from government scholarship has also seen improvements in terms of retention, especially in those rural and hard-to-reach health facilities. But also there have been recently there have been recruitments by Global Fund and the US government where they recruit staff and then they are placed on say 2 or 3 year contracts to work in specific communities, especially the rural areas. That has also benefited, and also with government committing to absorb those employees or staff at the end of the contracts with which are funded by the Global Fund or the US government. Yeah, I think that marks the end of my presentation. Thank you.
Excellent, Peter. Thank you so much for those reflections. You bring up a lot of really interesting points around some of the challenges that are emerging. And you know, the fact that something as simple as making sure that there are good working conditions, career advancement, security, and opportunities also for growth. I think that those are some of the things that people tend to miss out when they consider, how important it is that, the people who are serving the health system and serving people are, they're people at the end of the day, and they're simple things that we can actually employ as best practice. So thank you so much, Peter, and we look forward to engaging a little bit more later. But now I'd like to take this opportunity to welcome Rupert Milsom, who's the Associate Director of Workforce Planning and System working at Ashford and St. Peter's Hospitals, NHS Foundation Trust, and Northwest Surrey Alliance. I hope I got that right.
Thank you, Chair. That is a really embarrassing job title and list of organisations. But yes, hi everyone. My name's and thanks for having me here to talk and give me a little bit of a space to share some of what we are doing for the Northwest Surrey Alliance. So as said, my name is Rupert. I'm the Associate Director of Workforce. So my responsibility is primarily focusing on making sure we have the right skills in the right place at the right time to meet the health and care needs of our population. Next slide, please, Natalia. Thank you. So I'm here not only representing Ashford and St. Peter's Hospital, which is a acute hospital in Surrey, which I'll go on to talk about a little bit more in a second, but also representing what we call in England place. So place is an idea that we are trying to work together in a way which can give us economies of scale, but also keep the focus of our services very much focused on the needs of our communities. And it's also very much focused in the idea that the vast majority of the predeterminants of health aren't descendants of health and social care. They're things about local employment, they're things about local housing, they're things about local facilities and community and integration. They're all those facets. So the idea behind what a place is to bring together shared governance, shared responsibility, and shared view and vision and strategy of all those different elements of public provision to enhance the experience, the lives, and the quality of lives of our community. So that's kind of what a place is. Next slide, please, Natalia. So the Northwest Surrey Alliance. So the Northwest Surrey Alliance is a place. The clue's in the name. It's in the northwest of Surrey. So for those of you who aren't familiar with UK geography, so Surrey is one of the home counties, so just sits adjacent to London on the south side, and Surrey, Northwest Surrey, is the part which is immediately adjacent to London. So some of the things to note about Northwest Surrey are it is, because of its proximity to London as a global city, it has a house price which is 3 times the UK national average. So it's a very expensive place. So there are some areas of high affluence, but also there are some urban conurbations which are more deprived. So there is a stat which we like to talk about in Northwest Surrey, that there's a part of Northwest Surrey where if you walk for 15 minutes, the life expectancy decreases by 15 years. So a life expectancy going from in the early 80s down to somewhere in the high 60s. Now, that doesn't make an awful lot of sense in terms of us being able to provide health and care to those discrete and different populations in a way that generates equity, in a way that gives everyone an opportunity to make their maximum contribution, but also to get the most from their lives. So what we're really focused on is making sure we can account for all of those people, rather than just the ones which are traditionally accounted for within society. Next slide, please, Natalia. So our workforce, what our workforce look like. So the Northwest Surrey Alliance covers, as I say, the patch which is in the northwest of Surrey. It's It's made up of 120 or so providers. So those are NHS organisations, so National Health Service organisations. Those are primary care organisations, they're adult social care, they're voluntary sector organisations like hospices and day centres. So it really is a diverse alliance of people with kind of clearly aligned but slightly different ambitions. But the workforce that goes to underpin that for a population of about 400,000 is roughly 25,000. You're all probably better at maths than me, so add up those numbers better, but it's somewhere in the region of 25,000. Now that's a large workforce. It's a large workforce with diverse skills. Much of it is a regulated workforce, so has statutory criteria. But what having a workforce of that size means even if we are effective in terms of retention of our workforce, we're still going to be in a place where we're going to lose between 3,500 and 4,000 people each and every year. And when we're talking about particularly the roles which require a high degree of input in terms of training and upskilling, that becomes a very expensive endeavour to repeatedly replace those. So very much what I'm going to talk about is some of the interventions we're putting in place to try and help us in terms of managing retention in an effective way. Next slide, please, Natalia. Thank you. So obviously I don't have the space and the time to talk about every single thing we're doing. We've got a huge programme of work that's really very varied across a range of interventions. I think a way to tie it back and to give you some reading if you're suitably interested is most of what we're doing is very much aligned to the NHS People Promise. So the NHS People Promise, as linked in the as I've provided a link for there below, is very much focused on what do we need to do as an organisation to become an employer of choice. So how do we make sure our employees are valued? How do we make sure they feel they have the right level of agency? How do we maximise inclusivity? How do we make sure people have a psychologically but also physically safe place to work? How do we make sure we give our workforce all the tools and skills and abilities and equipment to do the best job that they can do for our communities? So that's very much where it comes from. Next slide, please. I'm going to focus just on three elements of what we're doing, and kind of these are probably what I would describe as the marquee elements, or they're at least the elements to which I talk about the most. So first of all is our place-based talent hub. So I think retention as a concept is not actually dissimilar to talent management. It's all about how do you nurture and grow the skills in your workforce to be able to deliver the services you need to deliver, but how do you make that satisfactory on both sides of the relationship, give people a career pathway where they can see the benefit that they can add and get the most out of what they want to do. So our place-based talent hub is very much focused around making sure we get the right people in at the start of the journey. So being really, really clear with our candidates what a job in the North West Surrey Alliance or within health and social care economy of North West Surrey looks like, some of the realities of that. And we're using some innovative techniques around virtual reality and giving people taster days and bringing students in for placements, so people get a really good understanding of what a career can be in this environment. I think from a UK perspective, I would say our population as a whole has a pretty good understanding of what a doctor or a nurse is. I think that hospitals are a thing people think about when you start to talk about the health and care economy, but people are less quick to reach for clinical scientists or healthcare scientists or some of the paraprofessional roles that go into it. You know, what's a physician's associate? What are all those opportunities that are not a doctor or a nurse? So part of it is a large kind of communications and PR piece around making sure that our local community is super invested and understanding of what it is we do and what their opportunity to contribute that is. But another really important tenet of it is about how do we take a view of retention which is shared across the alliance and all the providers within it to make sure we're managing that talent effectively. So we're doing a lot of talent pooling, which is about how do we record those people who we think are ready for their next step as a collective and make sure we can match them up with a role that remains within our partnership. So it's moving away from an idea of where we see retention or where we see turnover, or attrition in terms of people leaving our workforce as unhealthy, and start to see it as a potential gain to the system in which we operate. And that will give us an opportunity to start to think about how we strategically invest and how an organization can invest in another organization as part of its pipeline, and subsequently how that organization can feed the system in terms of producing a certain kind of workforce or giving a workforce a certain kind of skills. So some really, really interesting and innovative stuff going on in the Talent Hub. I'm really amiss not to have included a link to its website, because it has recently gone live in a new stage of its campaign, which is all about online and digital attraction. But next slide, please, Natalia. Place-based flow model. So you'll have to indulge me a little bit, because I am going to talk about data now. So understanding what happens to our workforce in any one period, I think, is broadly understood as really, really important to understand. So how many people join, how many people leave, when they leave, where do they go, why do they go, what are they looking for in that place outside? And I think we're really, really fortunate that NHS England and organisations in the UK, such as Skills for Care, support us with large data sets which help us understand some of those things. I think for us, an important part of that puzzle is to understand the interoperability and interrelationship of our workforces on a local footprint. So if someone leaves one of the providers in North West Surrey and goes to another, seeing that as a positive, but understanding what it is, because once we understand what it is, as I previously mentioned, we can start to measure it, we can start to manage it, we can start to influence it, we can start to invest in it in a different way. And I think it also presents us opportunities in terms of, once we reach that level of understanding, to start using some of our larger organisations within our alliance, some of our more established brands, particularly around the National Health Service, to act as an anchor institution and kind of adopt a shared brand model where we can use those understood concepts to attract workforce into the parts of our system which are less well understood by the public. So I think that's a really important step for us, and a piece of work which we are moving forward. It's not always easy because of the challenges around aligning data and information in relation to our workforce, but it remains one of our core ambitions. Next slide, please, Natalia. Thank you. This is the thing I talk about quite a lot, because what we do as so this is from an Ashford and St Peter's perspective now. So as an NHS organisation, we have a large and well-developed integrated human resources management system. It's called ESR for organisations in the UK, which means we've got 2,200 fields that relate to any one employee and their employment. Now, that's fields, not data points. Obviously, data points over time generates a much, much larger number. But we have been using some machine learning approaches to try and learn what that data can tell us about people's intention to leave before they leave. Now, as an NHS organisation with nearly 5,500 employees, it's very, very hard centrally in that organisation to keep touch with all our managers and all our staff very regularly to make sure we are putting interventions in the right place to speak to the right people at the right time. So what we're trying to do with this is twofold. One is to help managers understand where they've got a team member which is likely to leave their team, so they can put in place the right management around that person, so they can have the right conversations and where appropriate make intervention. But also, so as an organisation, we can, from a macro perspective, understand what our risk is in any one period. And where we've got to with this work so far is we can really clearly and with a high degree of confidence look at our employee base and partition them into who is at the most risk of leaving versus who is not, which has been a really, really useful thing to go through. It's really useful in terms of helping us understand what the motives are from a data perspective in terms of what are the markers that someone's about to leave, but also really, really useful in terms of putting that in the hands of managers. We've got big ambitions for this work in terms of taking it to the next level, in terms of including more data into the model, in terms of making sure that we have the right partitions in the data. So can we look at our workforce differently across demography, for instance? Like, does our young workforce, is it clearly motivated by a different set of factors than our older workforce? So that kind of level of partition, I think, will be really, really powerful. Now, I've been asked to ask you a question, and my question does stem from this. So I think all the variables that we measure for our whole workforce ultimately are latent variables. They're measures of something else. And I think the thing that is something else is how happy is our workforce. Now, we try in various different ways, doing national staff surveys and having performance-related appraisals and pulse surveys to try and capture what the mood of our workforce is at any one time. But we're never that successful in understanding it. So I'd be really, really interested to hear from participants what they or their experience of any novel approaches they've taken to simply measure how happy their workforce is. Thanks very much, Chair.
Thank you so much, Rupert. I think that was very exciting to even like some of the things you actually pointed out. Some of the other things that I've looked at was, again, the fact that this is really involving a lot of partners, especially in the NHS context, and how different organizations, I think you said about 120 partners, if I'm not wrong.
Yeah, it's around that, yeah.
Yeah, and I think that's really looking at it from a more system perspective, rather than just looking at it from like individual, where you have like someone leaving. And I think the interesting thing I also noted was, the shifted perspective on transition and leaving the workforce. And, instead of just saying that someone is exiting or leaving, it's looking at, are they going to shift to maybe one of the other organizations or institutions that exist, and what does that mean for the overall system? And of course, I'm really excited to hear about the data, looking at, those predictive models. It'll be great to see what some of the responses are in the chat from the team. So I will now shift to our next speaker. And I'd like to welcome Sergiu Otgon, who is the Head of Service for the Development of Human Resources in Health at the National Public Health Agency of Moldova. Welcome.
Yes, hello, Chair, and hello for everyone. It's nice to be here, and I represent here the 2023 cohort of Working for Health 2030. And I'm glad that I was invited on behalf of the team from the Republic of Moldova to share our knowledge and some information on the topic that the seminar 1 of cohort 2024, Working for Health 2030 program is focusing on. So please, next. Indeed, the topic of how we train, recruit, and retention tools we use in the Republic of Moldova is the topic of the presentation. And first of all, just to acknowledge that the Republic of Moldova is a Southeastern Europe country, which is outside the European Union at the border of the Ukraine and Romania. So on behalf of our colleagues, I was granted the permission to share our main challenges. And yes, indeed, although we are in Europe, we have mostly the same problems as everyone else in the field of human resources and health. So the questions that our department tries to answer and to provide evidence-based knowledge for the policymakers are the actual numbers of professionals enough? How do we attract more young professionals to the sector? Are the actual retention mechanism in place good enough? And what levels of income and wages are expected and wanted from the healthcare professionals in rural and remote areas especially? These are only some of the questions that the policymakers are putting in front of us, and all of them are with the emergency level of response required. The next one. We have, although some issues in the healthcare field, we can arguably say that the healthcare workforce education system is well placed. We have all kinds and levels of medical education available within our country, so there is no need to go abroad to study. Starting with the university degrees that prepare doctors, nurses, specialists in public health. We have also college degree or centers of excellence that prepare registered nurses, midwives, dental assistants, and lab professionals. Also, we have postgraduate education. We provide master degrees, PhD, some kind of specialization in the most of the specialties that we provide, and also continuous medical education on-site and online within the country, and the possibility for our counterparts to share and to study and to visit national and international conferences. Next one. Although the education system is well in place and we have many international students that we come each year to study healthcare in our university and centers of excellence, there is still a bridge from the education system to the employment itself. Because we are a neighboring European Union, there is always a degree of migration students and graduates that opt to migrate and to work in other country than the Republic of Moldova. So there are several binding mechanisms in place approved by the government to keep the healthcare workforce within the country and within the public healthcare system. So we started with a couple of €1,000 7 years ago, and now we gradually increased the financial incentives that are allocated for healthcare professionals that opt to go work in rural areas within the country. And beside the financial, we have other incentives instead of money: travel cost reimbursement, energy bill support, and some preferential mortgage rates for the first house on healthcare professionals. Although the financial incentives and the non-monetary support is available, not all graduates choose to work in public sector, most in rural and remote areas. So there is a mechanism to have a mandatory 3 to 5 years of work in public health sector upon graduation, based on the Ministry of Health open vacancies in public sector. Next. And about the retention, is there good enough healthcare professionals and enough numbers of them in place? It's not so easy to respond because as in all other countries, the trend is not in our favor. We have demographic switches, we have changes in retiring age and the lack of attraction for young professionals to go choose healthcare sector. So just to focus on the Republic of Moldova itself, we have around 40% of healthcare workforce, 55 years and above. And still we have up to 10% of open vacancies not filled in yearly. As I mentioned before, we have about a third of young graduates only covering the open vacancies, and the rest of newly graduates opting to choose another sector, private sector, or go abroad. And we have this neighboring Ukraine conflict also pushing our healthcare workforce to go and try to switch the country of residence and maybe go in a different country. Also is pushing our healthcare professionals outside of the system. Next. We have also some strategies, national level human resource and health development strategy. We have overall health development strategy and digital transformation strategy in place, approved by the government. And we also have national and international cooperation, mainly with WHO, European Commission, Southeastern European Health Network. But seems that this is also not enough. Next. And I want to add a little bit as a graduate of the cohort 2023, how this program impacted us, myself and my colleagues. Next. First, I want to share that Action Learning System program is something you also need. It will teach to think and act differently as before. Just to briefly open the brackets, that LLS is not only about webinars or presentation, it's also about seminars and your dedicated time. You will be provided with peer supporters, facilitators, and also all kinds of materials that will help you learn, and your team members also involve and be more proactive, discuss between you and with other healthcare professionals in your country and outside of it. And also, if you have a big problem, which will be put in front of you, during this year of LS, you will for sure, you will find most solutions to these problems. And the next. Just to conclude, I will have some testimonials from my colleagues that full focus with happy faces, it's the main topic of our team. And some colleagues said that eventually we will solve the problem, but with LS we will achieve this faster. And also another colleague said that if you have a weak problem, then LS is coming to you. And my own opinion is that one day a team went through Action Learning System and the LS remained with them forever. And next, the question for you is how, in your opinion, the artificial intelligence or digital tools related to AI will disrupt the recruitment of the healthcare workforce? Thank you.
Thank you so much, Sergio. I think you brought out the financial and non-financial incentives that governments are really focusing on to try and make sure that there are, substantial incentives for people to join the health workforce, but also keep them within the health workforce. And, the fact that also the government and in different systems are grappling with demographic shifts that, we really have to combat. So thank you so much for those reflections. I think they were extremely useful for the discussion and also for the question that you raised at the end. Again, looking forward to the answers that we'll get in the chat box. So now I want to just shift us back to Simphiwe, if you're online. I want to give you a chance to finalize your presentation in 1.5 minutes so that we can jump into the Q&A session. So Simphiwe, if you're online, please join us, unmute your microphone and turn on your camera. Simphiwe, if you're there. All right. So as we wait for Simphiwe, I think so we'll focus first. Oh, Simphiwe, there you are. All right. So Natalia, if you could just go back to the presentation, to the last, I think the last couple of slides that Simphiwe had. But over to you, Simphiwe. I think your microphone is on. Yeah.
Yeah. No, thank you, Chair. I am actually gonna project from my side.
Okay. Great.
If Natalia agrees with me, okay. And I should be able to be here. So, Chair, thank you very much for this opportunity. And I was actually at a point where I was just talking about the policy proposals and recommendations. And I'm actually glad to hear the other speakers making reference to some of these. And I also noted about 5 questions in one from the Q&A platform. And I think I'll just respond to those as we are discussing. But I think the last part that I wanted to really reflect on is in the 18 countries that I work in the Africa region, Eastern Southern Africa, when I engage with health workers, and the message that I'm getting is they would like to be prioritized. And it then reminded me of a quote by Maya Angelou when she said, I open quotes, never make someone a priority, whereas all you are to them is an option. So, and I close quote. And I think the health workforce, we now need to step up the game in terms of ensuring that they remain a priority in terms of the work they do. And thank you to Natalia for posting my question, because my question was around how can the decent work agenda be applied to improve the working conditions and job satisfaction of health workers, particularly in terms of fair recruitment practices, continuous professional development, and retention strategies. Thank you very much. Thank you, Chair. Back to you.
Excellent. Thank you. Thank you so much. And I think you've all the colleagues online have shared really interesting questions. So of course, starting with yours, Simphiwe, the decent work agenda and applying that to improve working conditions and job satisfaction. And I think the other question we had from Rupert was on novel ways we can measure the contentment of our workforce. And that's again very, very critical question, because that has some implications. And then another question from Sergio on how might AI affect recruitment or retention in future. So I'm going to flip the questions a little bit, and I'm going to actually start off with some of the responses from Rupert's question around the novel way we can measure the contentment of our workforce. So the feedback from the chat is around some of your responses are, it would be good to have one of those smiley face buttons that you see the airports next to the clock in, clock out machines to staff. And the staff could then say how happy they are as they leave work. I imagine this will vary day to day, particularly if you've had a very long or difficult day, but it will give you some insight. Then another response is, you always hear that most people leave jobs because of managers or people and not necessarily because of the job itself. And that might not always be captured in exit interviews, particularly if you work in a close-knit community. So how do we consider that in terms of our measurement processes? And there's a response here from a colleague in Wales, health organization in Wales. We have created an online thinking of leaving form to capture staff who might be thinking of leaving, so we can find out the reasons why and put interventions in place and retain them. Which is it's different from an exit form, exit interview, which is usually only done after resignation. So the person says, not sure how novel this is, but it would be good to mention. I think that's a really important thing. And then yes. So the next response is yes. Happiness, purpose, satisfaction, and enjoyment. These are conversations that can be had with individual teams to help define their purpose, and something like the National Staff Survey can capture metrics on satisfaction and enjoyment. Arthur Brooks works on the importance of measuring happiness at work, which is a worthy read, according to this respondent. And exit interviews vary within the NHS, but can be captured on ESR. I'm looking at some of the other responses to this question, but are there any quick reflections you have so far, Rupert, from those reflections that you've heard that you want to jump in and talk about?
Yeah, happy to. I think they're really strong suggestions, aren't they? And we've done a lot around, as I say, trying to survey our staff, but the challenge you get is, one, the response rate isn't always going to give you the total view. It gives you a slightly downside view, and also, how do you inspire people to really tell you what their problems are, as I think you mentioned, Rispah, in terms of, but remaining keep the confidentiality, but also be able to make an intervention. So I think there's some real challenges in there. I hear the thing about the thinking of leaving stuff. I've been exposed to some really profound work in the past around some really effective what they call itchy feet conversations. So when you're thinking of leaving, I think those could be so powerful. But a challenge we come back to often is do the first line managers actually have the levers in terms of the ability to respond to the thing which is being raised by the employee. So if it's a challenge around pay or circumstance or housing, how do we support managers to be able to support our workforce in those regards? So really challenging. And I love the idea of, it doesn't need to be sophisticated, does it? Even like most of our workforce is on a computer every single day, a little pop up in the bottom, click a smiley face or a sad face or some degree of a scale. I think there are lots of options, lots of options, but it's just about making it easy for people and giving us a broad view as well, I think.
Right. So I still see a couple of questions around or reflections rather around that, because I think one person says here, gaining staff engagement, as you've said, Rupert, feedback is challenging, and I am not sure there is a single approach for success. Within the UK, as Rupert has mentioned, there are a raft of surveys approaches, but gaining responses is challenging. When speaking to staff regarding this, several themes emerge, which include survey fatigue, apathy, and disengagement, as when staff have provided feedback previously and it's not acted upon. Based on this collaborative and well-planned engagement approach is key that demonstrates active listening, learning, improvement. So I think there's a point there around, we do want to get information from staff, but if they feel like it's just going to, take away their time and it's not going to be useful for them, it'll be difficult for them to be able to effectively engage. They'll not have any buy-in if they don't feel that they're being heard or being listened to. Just moving on to, I will go up into Peter's. So there's a question, that is actually coming from the audience to Peter. I think you had mentioned, government bonds and as a way, for governments to be able to engage with staff and make sure that the staff stay on. But the question to you, Peter, is around, have you ever encountered, challenges or resentment among staff when signing bonds? And this may also, I'd also like to split this question both to you, Peter, and also to you, Sergio, if you have any reflections on that. And team, colleagues online, please feel free to keep pointing out any answers you have for any of the questions from any of the speakers. Please put them in the chat box so that we keep engaging. This is now your time. It's a chance for you to put your voice out there, reflect on what's been said. So please do. So I hope I gave Peter and Sergio some lead time to think about that question. Peter, do you want to go first?
Yeah, sure. Of course, obviously, there are challenges with any process or system. But if you take it from my perspective, that in Malawi, healthcare workers' earnings are very little. So their wages range, say, from maybe $150 or $200. So whenever government puts out scores for application for scholarships, for saving staff, everyone is happy to apply, and everyone is happy to oblige to the conditions of the bond. But I think there are two aspects. There is the aspect of enforcement on the part of government, because if I take, for example, medical doctors, if they go to do specialist training abroad, say in the UK, majority do not return because they find that the salaries and the other benefits are better there. And then government is kind of helpless because they don't have really any mechanism to enforce or to push those people to come and work in Malawi. I think that has been a weak area. There are also some scholarships offered to staff working locally in the country, lower level staff. The challenge is the same. So they would be bonded to say you work in this rural area for, say, 3 years, but then when people return, they will just either move away to an urban area, maybe following a wife or a husband. And I think the enforcement component has been a biggest weak link. But I think the spirit of the bond and the regulations have been great, but the enforcement part, and staff are happy to apply because they don't have money to pay for their own tuition to attend advanced trainings. Thank you.
Thanks, Sergio. Do you have any responses to that question?
Yes, just a short remark on the previous topic, that the intention to leave surveys are, I think, a very good tool, because in our country we have like a separate room where every healthcare professional needs to go and provide his documents before even trying to leave. And that room is maybe like a boiler room, you know, the emotion of the healthcare professionals. He already decided that wants to leave, but still not resigned. So that fraction of period of time is maybe essential to question him, because the professional is ready to provide his arguments why he is leaving, why and what is bothering him in the system. Maybe his opinion, what can be changed. And using this opportunity, we can extrapolate the results to the policies, to the healthcare that still think about, not making the first step. And another comment is that in the Republic of Moldova, we have mostly the education is free based on budgetary financial support. So it's in a way morally correct for the government to put this binding and mandatory 3 to 5 years time to work for the public sector after graduation. So this is in a way in an equal position. The government provides the funds for you to be established as a professional, then you have to provide your professional expertise at least for 3 to 5 years time. And hopefully in this period of time, the professional will gain roots in that region, maybe have a family, children, some relatives there, and will be able to keep up. And another comment is that the Republic of Moldova last year granted the European Union candidate status. So hopefully when we will be like EU members, we will not have this official migration of healthcare professionals, because we will be like the same community. And without these borders, I think our healthcare professionals will not even be obliged to provide the information that they are leaving. They will just resign from the public sector and just go 100, 200 kilometers away, another country. So this is also a situation that is already on the horizon for our country. Thanks.
Great. So, and actually, while we're still on you, Sergio, your question around AI, I see there's a response from one of the colleagues online around the incorporation of AI into healthcare recruitment is revolutionizing the health sector. Although AI simplifies procedures, the necessity for human discernment still persists. And recruiters continue to assess cultural compatibility, soft skills, and other subtle qualities that AI cannot completely grasp. For instance, through automated screening, AI algorithms can scrutinize resumes, pinpoint pertinent skills, and align candidates with job specifications. Additionally, predictive analytics, chatbots, virtual assistants, skill gap assessments, bias mitigation, remote hiring, and talent pipelining are also emerging. So do you have any responses to that based off of the question you asked and the response the colleague has given?
Indeed, there is a fine line between artificial intelligence and emotional intelligence, because only to filter the resumes or the background, the CVs, the notes or comments that maybe the healthcare professional provide in a written form will, I think, never be enough for a healthcare institution to evaluate the candidate. There will be always human touch, a necessity for interaction, for communication, face-to-face, maybe a communication test with the patient also, which artificial intelligence at this point still lacks the human touch.
I was trying to come off mute. Okay, so I think that's kind of giving us, some of the ideas, because I think there's a lot of challenges and a lot of potential best practices that we can employ as we move forward. But there's another question I see here around, us not having really gone into the international migratory workforce question and how we ensure equitable and ethical recruitment. Now, I'm going to jump to Simphiwe and ask if you want to take that, in addition to any of your other questions that you've seen on the chat that you want to respond to.
Yeah, no, thank you, Chair. Yeah. Let me first acknowledge the 5 questions in one that were asked by Eleanor. And I think I actually have to respond, to those questions as well, and probably maybe briefly on this other question in relation to migration. The one question that Eleanor was asking was around the issue of unemployed health workers. And when I was looking at this question, I immediately reflected on that diagram that I showed regarding the world of work, because the world of work is characterized by people who are unemployed as well. Now, whilst we don't have, currently we don't have specific interventions that are related to unemployed health workers, but we collaborate with WHO on issues related to health workforce employment. And I think one is taking this, as one of the areas that we need to specifically focus on, because if you look at that diagram, and I spoke about people who are looking for employment, and I highlighted people who have exited employment, and we have examples in other sectors, for instance, like mining and all that. So those lessons can also be drawn from there. But the second question, Chair, was around the challenges in absorbing trained health workers, particularly in Africa. And there's several factors that contribute to this. And I think Eleanor, she's in the research space, would also be aware that it's also linked to budget constraints, where many countries in Africa, they struggle with limited healthcare budgets. And sometimes, yes, the resources, financial resources would be there, but it then goes into a matter of prioritization as well. So it's very complex. And infrastructure limitations, of course, it's another reality for us. Urban-rural distribution, there is an issue of mismatch between training and the local needs, because sometimes training doesn't align with the local healthcare demands that are there. Then there was a question around informal settings. And the answer here is working with health workers in informal setting, it's a big yes. And that is why, and I may not have used this line, Dr. Walumbe, earlier, but I think some of the solutions, that to the challenges that we are faced with, they require involvement of other stakeholders that are not normally, health actors. So solutions lie elsewhere. And I'll give you an example, and that's why I presented on these standards. There is a recommendation in the ILO, recommendation 204, which is focusing on informal economy. And these recommendations are wide enough to look at various sectors that would have informality. For an example, the benefits would be to improve quality of care settings, in these settings, enhance regulation and oversight, providing opportunities for further training and skills development. Then the last two questions she was asking was the relevance of ILO's work on informal workers. And I think I've just spoken to this. And I think, once again, promoting occupational safety and health is important. Encouraging formalization and social protection. And this is exactly what the recommendation 204 is talking about. And colleagues in the health sector may not be aware of the contents of this recommendation 204 because it's kind of supporting other sectors. So it would take this multi-sectoral approach to bring it and make sure that it is relevant. And then the final one, the health sector norms and applicability of tools from other sectors. Whilst the health sector does have unique characteristics, and then we really acknowledge that, but many general principles of labor and employment, they still apply. However, some aspects that might require tailored approaches would include your professional licensing and regulation, continuous medical education requirements and all that. And my colleague Maren Hopfer, who is probably on the call, we work together to make sure that we collaborate with other units within the ILO so that we can bring this more integrated approach. Chair, let me stop here. I really would like to hear more even from the other people online. Thank you.
Thanks so much, Simphiwe. And I think that there seems to be a question that I think is persisting in the chat, and I'll open it to any colleagues who want to come in and answer. And it's still on that question around migration and brain drain. And I think Suresh has even just pointed it out once again. And I think this is something that's cross-cutting. We've all talked about how, certain healthcare workers will try and migrate to high-income countries. We've talked about salary and wages being a challenge. We've talked about working conditions and making them want to shift. And part of that shift is actually shifting out of the country. So, and starting off with Peter, I don't know if you want to give some of the reflections from the Malawi context as we start for the rest of the team. And it's really around that issue of migration. And are there any ways we can talk about brain drain in a way that it really reflects the challenges that people are experiencing and the choices that people have to make? And these are some of these choices are actually they're economic choices, right? People are making these decisions because they want to look for better opportunities that reflect their current situation. So I don't know. I'll start off with Peter, but this is really a question which is cross-cutting. On brain drain and migration. So Peter, I don't know if you want to come in and speak on this.
Yes, so I think the situation of Malawi is pretty much similar to most countries in terms of issues of migration. But I'll give a typical example. towards the end of last year, coming to 2024, the country had thousands of nurses who were looking for work. And what we noticed was that the nursing unions started agitating for these nurses to be exported or deliberately exported to other countries. And I think while we know that in the country we have very high vacancy rates across all the nursing disciplines, but because these people could not be absorbed in the public system and they needed to earn a living, they started asking government to let them work, say, in Japan or in the US or in the UK. Now, while this issue was under discussion because government wage bill within the context of IMF agreements could not absorb the nurses, the Global Fund and the US government and others came in and recruited all the nurses. Now, the point that we learned from this scenario is that while, of course, they would have loved to go to the US or to America, but we noted that the moment government offered them this opportunity, none, maybe not none or not all of them, but at least the majority joined the public service in country. And the movement that was there from the nursing unions to push government, because they were marching on the streets, giving out interviews on radios, that kind of died down. Now, what we see from this is that healthcare workers are happy, maybe to an extent, to work in their countries. But of course, there are those who wish to make more money and go to other countries. I think that cannot be ruled out. But we noticed from this experience that majority have stayed in the country and they are no longer agitating to go to work in other countries. So hopefully, creating working opportunities for nurses, doctors who are graduating from our local universities, we noted that we can retain them in country. We can reduce demand for migration. But I think it's just a matter of making sure that those opportunities are there so that when these healthcare workers complete their training, they can be absorbed in the national or the local labor market. I think that experience has really taught us that it's not everyone, or it's not always that people want to go out there, but if also there are these opportunities locally, they can stay. Hopefully they will stay long, because of course there are those that after maybe a year or two, they want more money, and we may see the trends changing. But so far, I think the situation is that they are staying and they are working within the Malawi public health system. Thank you.
Thanks, Peter. Rupert, I'm going to put you on the spot to give a response to that, if possible.
Yeah, no, absolutely. And I will tread very carefully because I appreciate this can be an enormously contentious and emotive area. I think Peter's very right. I think money is not the only part of this. There's a much more complicated and multifactorial kind of drivers to it. I think in the same way that you've heard me encouraging us to think in a system in a hyper-local fashion, and this is going to be very easy to say and incredibly hard to do, but I think there are more opportunities than we take in looking at our global health workforce and investing in partnership in the way that we need to do to make it a more equitable situation. I obviously, as I mentioned, North West Surrey is a very, very affluent part of the UK. We have a very, very high level of international recruitment into our health and care organisations, up to half the intake in some years, and that's been a big driver from the ambitions of the previous government. But it does present challenges on the receiving side as well, around making sure we can account for a workforce which is more diverse, ethnically, culturally, in terms of aspiration and background as well. But I can't help but think part of the work that we've already been doing in the UK and the NHS England have been really focusing around the kind of mantra of earn, learn and return. I'm sure we're quite good at the earn and learn and not so good at the return, but it's working out about kind of in taking the view as to what the returning factors are, in terms of we also need to work out what the attractors to become globally mobile are, but what are the attractors in returning as well? Because I can't help but think that I don't have any numbers at all to understand what the proportion of people who emigrate who emigrate, return. But I can't help but imagine there's a stage in people's life when they feel like being where they came from and being around whatever they left behind in terms of family and community becomes more important to people. So I wonder if there's more we can do to exploit that and take that earn, learn, and return view on a longer context to making sure we're giving people that kind of opportunity. But yeah, hugely contentious and emotive. I appreciate that.
Thanks, Rupert. You've treaded very well. Don't worry. So Sergiu, do you want to go and take? Do you want to take that?
Yes, I was reading the chat and went through some questions there. They are quite difficult questions to answer because they require some percentage, some resources. So I provided my email for the person who asked them in order to respond. And about the brain drain, brain gain issue, indeed, I think there's a not brain drain instead of, because we already lack the brain, just to say it this way. We still have not enough potential to cover the open vacancies on the current recruiting rates, because as the question in the chat was imposed, we only cover 20 to 25% of open vacancies based on the recent graduates. So you imagine if we have a retiring age of 40% of healthcare professionals close to retiring age, and only covering up to 20-25% of them, what will happen in 10 years' time? We will have half the healthcare professionals that we have today. So we not even gain the brain to lose them, because it's still not enough for young professionals going to healthcare to choose the medical education and to cover the existing open position. So in this case, it will be difficult to cover just based on the natural flow of things. It will require some aggressive recruitment or some mandatory binding mechanisms for the existing staff that risks to increase the burnout and the mental issues that the healthcare could have in the future. It will require the existing staff to go work additional hours, additional shifts to cover the existing position and the existing necessities from the healthcare, for the healthcare from the population. So it's a tricky situation. Indeed, it's something that we need to think about already this years to have maybe a working tool in 5-10 years time from now. Thanks.
Yeah, thanks so much, Sergiu. And I think I do appreciate that this is a very difficult question, and the contexts are extremely different, and the solutions, can't be applied broadly. We have to really think about all of those nuances. And Simphiwe, as I come to you, I think, only also to answer that question, but also now I want us to focus more on distilling those lessons that we've learned. And Maggie actually, asked, to you, Simphiwe, what common and distinct lessons on decent work can you share from across the 18 Southern African countries? And what would be the ones that you would say have been extremely critical in maybe shifting the needle a little bit? Over to you, Simphiwe.
No, thank you. I think what I want to highlight, and this is also based on how I illustrated the world of work, how that space, that environment, the world of work, how regulated it is. because when we talk of these international labor standards, which are cut across various thematic areas, but what is common about them is they are international labor standards. Whether you are in transport or mining or health sector. But one of the biggest lessons that we've learned now is we need, once the health sector has distinct characteristics, but we need to bring it closer to the employment and labor space. And what I mean by this, the countries, and many countries actually who are member states of the ILO, there's what is called fundamental conventions. And this includes your tripartite consultations where you have leaders in government, leaders in business, leaders in civil society coming together. So, and they would highlight priorities within employment and labor. And there's a framework called Decent Work Country Program for each country. And if you look at the Decent Work Country Program for the 18 countries that I cover, you realize that health will not be pronounced, the same way as others would. Fair enough, you will find employment there as a priority. But when you look at the detail, you realize that, look, it doesn't necessarily, specify the sectors, including health. So I think the biggest lesson is for those of us who are working in the health sector space to mobilize each other and be part of those dialogues, because those are the dialogues that determine the agenda in terms of what has to be financed in terms of employment and labor. Chair, I also want to quickly link this to the question on migration and probably the lesson learned as well. I think though it may be obvious, the issue of patterns of migration, whereby we would have your internal migration. The country that I'm based in, South Africa, has rural and urban areas. So there's movement between the provinces, some are urban and rural. So I think we should take cognizance of that. And then there's regional migration between African countries that we are seeing. Then there is, of course, international migration where people are going to high income countries and all that. So it's always good to then look at some of these lessons that we are picking up, where we are seeing that the bilateral agreements between source and destination countries, they are working. They may not be the single solution, but they are working. And then the improvement of working conditions and remuneration in source countries is also another consideration, which I think it's a policy issue. Policy responses. And that's what we also picking up, that where there are policies that are responding in this particular way, there is some kind of improvement. And then targeted rural retention strategies. There are many countries in Southern Africa, for instance, that now have developed these targeted rural retention strategies. And of course, there would be issues around the networks that are being established. Yeah, but I do. But the last point, Chair, sorry about this, the issue of social dialogue, I used this term earlier, and I used health workers' representatives. And when I say this, I'm referring to unions in the health sector. I'm not necessarily referring to professional associations. So that is also another issue, because the agenda and the cause that the trade unions in the health sector would actually address may not necessarily be the same as your professional association, so as to speak. So I think those dimensions should be looked at as well. Thank you, Chair.
Thanks so much, Simphiwe. And I'll come to Sergio. Do you have, you've talked about the Moldova experience, and I think there's some of the lessons you've learned have been around, for instance, like the discussion around the incentives that you've managed to put in place and some of the effects that have come from those incentives. Do you have kind of like 3 key lessons that you would want to share with the team here around what's, what you've learned. And also tied to your question, I think there was a response from one of the colleagues that even as we look at AI, if AI will be incorporated into healthcare services, we must have a foundation or amendments to implement, because we have to seriously take ethical and moral considerations. And that's from Matthew. So it's aside from just the recruitment part of like AI and digital technologies, and really focusing on even the service delivery. So do you have any lessons that you would share around the Moldova experience?
I think the most important one, it's not enough. So it's 3 words in one sentence, because we started with financial incentives, I think 10 years ago, somewhere maybe 10 times lower than today. So the trend is a little bit lowering, but still the financial incentive is not enough, because 10 years ago, remote and rural areas were considered, let's say, indeed remote, because there was no internet, maybe no TV cable, no roads to access the healthcare facility. The house, the villages that were in place were not sufficiently maybe considered as enough for decent living. And the financial incentives that were generated and provided that time were way not enough to convince young professionals to go work in that areas. Nowadays, even the most remote villages almost sure have a stable internet connection. We have infrastructure, some roads connecting the village to a decent city, maybe not a big one, but enough with young children, kindergarten, for example, schools, some recreational sites there. And the housing is also available, heating, electricity, any kind of support is provided from the government. And also the financial incentive increased several times. And it's still not enough to this point, because already the young ones are orienting to abroad, to other countries' standards of quality living. The internet and the mass media, also social media, promotes a higher level of living, and the younger generation are aiming to be all millionaires, And that's why even a decent value of money that the government provides for young families, imagine if you will have 2 young healthcare professionals marrying and going to rural areas, there is a decent amount of money that they could have from the government, and they will this will be a good start for them. But unfortunately, this is still considered not enough. And about, I was checking also the chat, a question was about the rates of young professionals choosing to go to remote and rural areas. When the financial incentive started, the rate was only about 25–30% percentage of the graduates going, according to the Ministry of Health, to open vacancies in rural remote areas. In the last couple of years, the rates increased to 85–90%. So we can consider that the younger generation already have this in mind when choosing to go and study healthcare, that in the end they will most probably going to work in rural and remote areas for a couple of years. But they also accept the financial incentive for this as being at least a decent, appropriate one. Not enough, but appropriate one. So the rates speak for themselves. There is an increase. Overall, we have also some testimonials from the young professionals that went to go in rural remote areas, and once upon a time, a couple of times per year, the Ministry of Health provide their stories, how they choose to go to rural areas, how they establish themselves there, and how they keep going professionally in the rural areas. Thanks.
Thanks, Sergio. And I'm going to jump to Rupert. And I have a question here, other than your 3 lessons that you want to share. There's a question here in the Q&A around, and it's picking up from what Sergio said, around the different generations that exist within our systems. And here, Drew Phillips says, happiness, there's a significant body of research across all employment sectors highlighting the differences between generations, such as Gen X, Millennials, and Gen Z. These generations have distinct perceptions regarding flexible working arrangements in life, tailored benefits, rewards and recognition, and professional development. So given the fact that the NHS has mixed generations, would it be useful to examine this area as a range of options to measure happiness may emerge and lead to novel approaches to enhance work environment?
Well, the short answer would be yes, wouldn't it?
Yeah.
But I suppose the longer answer is, I think we've all come to a place where we understand that across our workforce, so roughly spanning 50 years from our youngest to our eldest, they're going to want very, very different things. They're going to want very, very different things because their experience of life to date has been very, very different in terms of their experience when they were going through their formative years. Their expectations are going to be very different depending on where they are in their stage of life. We understand those things. I think there are parts of this which are very, very complicated, or maybe not complicated, but challenging. So being a national public sector organisation, we've got a very rigid approach to terms and conditions of employment, because that gives us an idea that we're applying equity across our workforce in terms of we don't have areas where people are paid more. We've gone through some very, very painful processes in the past in the UK to get to a point where we have standardized terms and conditions across our NHS workforce, which is about 1.5 million people, so very, very large. I think there's a really, really keen focus on making sure that benefits are more dynamic, so you can make sacrifices in some areas for others. And I think that's a really good opportunity we have in the North West Surrey Alliance, being a collective of NHS and non-NHS organisations, local government organisations and voluntary sector ones, that we've got, within our 120 organisations, we've got, a fair few different variations of terms and conditions. Some organisations having more softer benefits, so higher annual leave, good pensions, others focusing on pay. And I think if we can leverage that as a set of organisations and say, which of these as an employer, and if we can become agnostic as employers of each other, or the barriers between employers, and say, for you as an employee, what would really work for you from these different sets, and select those, I think we've got an opportunity to operate in a way where we kind of view the different elements of reward and recognition as kind of a bit of a sliding scale. So I do think that's really, really important, because I think it's important to meet people where they are, and accepting that we've got some people who are in very, very different places. I suppose it's just on the AI element of what Sergio's been saying. It's, I can't think who said it, but it wasn't me, but the person who said that it's not going to be AI that takes your job, it's going to be someone who knows how to use AI that's going to take your job. I think that's an element of this, in that our artificial intelligence, generative AI, machine learning, those are never going to be the core business of our health workforce. Our health workforce will still, the core business of them will still be people. But that's not to say it won't transform the role they're going to be doing and the way in which they do it, the way they can operate in terms of deploying generalist skills into specialist fields using the support of AI. I think is a really, really interesting prospect. But the thing that it just makes me think time and time again is that, you know, from a UK medical education perspective, you know, the doctor who's going to be a senior doctor in 2040 is starting their training in September. And I don't know that we account very well for accounting how different that world that they're going to operate in is from a technology perspective. So I think we need to get onto it quickly. But I do think it has massive potential, but also obviously all the other elements that come into using it for people practices. So around recruitment, around, you know, the ethics of letting the machine do it, and so on and so forth. But yeah, I think it's going to be really, really transformative. And I think we're probably doing that thing we always do, which is we underestimate the impact or underestimate it, I'd imagine.
Thanks, Rupert. Really useful and exciting reflections there. And coming to you, Peter, what would you say have been the 3 lessons from Malawi that you have learned, that you want to kind of share as a parting shot, especially given the fact that one of the questions here that I've seen is around, you know, what's really the challenge when it comes to actually taking on medical professionals who are, you know, unemployed in the sector and they want to join the space, but there's limitations, there's fiscal limitations that limit what, you know, that recruitment. What are some of the lessons you've learned, and what do you want to share as kind of like a parting shot as we close?
Yes, I think as colleagues have highlighted, in the Malawi context, our economy is constrained by many factors. So often government is limited in terms of how many healthcare workers they can recruit in each and every calendar year. Yeah, but I think collaboration with partners is one of the things that I've seen has really helped to absorb as many healthcare workers as possible, which has limited the need for migration to some extent. So I think these collaborations with the Global Fund, the IMF, the World Bank, the US government, the British government, I think these have really helped us to stabilize the migration. But also the issue of, I mentioned in the presentation, the issue of housing, especially in the very remote and rural areas, because there are some areas where if you consider you have a graduate nurse or a medical doctor and the health facilities do not have decent housing, these young people definitely will not really go and work in those areas. But we have seen that even in areas where there is no internet, but at least they have piped water, they have got a nice house, maybe with solar power, healthcare workers, even the young ones, are able to stay in those locations. So I think that's also something that as a country, we are pushing to make sure that as many housing units are constructed in these very remote areas, because also in my presentation, I highlighted the fact that Malawi is predominantly rural, with over 80% of the population in the rural, but there is a very big mismatch in terms of healthcare workers, where you have possibly close to 70–80% of the health workforce serving the 20% of the population, precisely because of these challenges of housing, maybe there is no water, and to attract these young professionals to work in these areas, it's a very big challenge. Finally, I think government policies also in terms of adding on some incentives to healthcare workers working in the rural, I think it has also helped, because there are some top-up allowances for health workers who are working in the rural, which those working in urban do not get, where staff working in rural, they don't pay any rent, maybe they pay for water, but a very small amount. Those are also some things that government has tried to incentivize the need for staff to stay in these rural areas. So I think for me, these are some of the key things that as a country we have learned I also hinted on the bonding mechanism, which for the staff, it works, but I think it needs more enforcement on the side of government, even having country-to-country bilateral agreements, especially countries like the UK, where most of our doctors and nurses go, so that if, for example, a medical doctor trained in Malawi goes to work in the UK, maybe the UK government helps us to train maybe 2 or 3 doctors to replace the ones that are leaving. I think those conversations could also help us really to beef up our numbers, because to be fair, as I mentioned, our vacancy rates for the critical cadres as high as 50% or 60%, even 70% for the specialist cadres. Yeah, so possibly I would end on that note. Thank you.
So, first of all, thank you, Peter. That was very, very helpful reflections. You know, something as simple. I've actually been a beneficiary of receiving housing in a rural area, and not having to pay bills, and that or having very minuscule bills that you're paying. And I do know that even for my colleagues who worked alongside with me, that was something that really incentivized us actually not to want to go into the urban areas in the cities. We wanted to stay within the rural area, because even the cost of living was generally like lower. So that's just a pointer I think I reflected on, and it's very useful. So as we come to the end, I want to first of all extend my most sincere thanks to our speakers. Thank you so much, Simphiwe. Thank you so much, Peter. Thank you, Rupert, and thank you, Sergio. You have given excellent reflections for people to really think about, and the questions that you managed to share have been extremely useful. And I think we created a really good foundation and managed to tackle actually our questions very, very well. I also want to share my sincere thanks to the WHO and partner countries for sponsoring the program and the continued relationship with the NHS England. And I want to also say a special thank you to all the participants, to all of you for sharing your reflections, sharing your questions, responding to some of the questions that came from the speakers. It's been extremely useful.